Thanks everyone for coming. Hopefully the roads are still fine when we leave. So I'm Ashley Dupuis. I'm one of the OBGYNs here at Lakeland. I started here about 2 years ago, 2.5. So tonight we'll be talking about menopause and sort of that time leading up to menopause. So that's why it's called navigating the change. It doesn't just happen in one day. There's a lot of things that start happening in the few years beforehand. So we'll go through some of the common symptoms of menopause and ways we can alleviate those or help from a medication or non-medication standpoint, and just how to go about that. And then at the end, I'm sure there will be some questions, so we'll leave some time for that too. But thanks for coming. So some of this might look familiar. The fan is especially a good one. I recommend a handheld fan for anyone going through menopause. But headaches, depression, hot flashes, those are some of the common things we'll talk about tonight. So menopause, by definition, is the permanent stopping of periods after loss of ovarian activity. So that cannot be determined until your periods have stopped for 12 months. The average age, at least in North America, is age 51. So that means some people it will happen in their 40s, some people, I think the oldest woman I've seen going through menopause was 60. So I don't wish that upon any of you, but it can happen. In the years leading up to menopause, things do start to change. So that's the menopausal transition, or perimenopause, you might hear it called. And that is about 4 years on average. So if you're starting to get some of the symptoms that we talk about tonight, cross your fingers, hopefully you'll be through menopause within about 4 years. Some people have it really easy, and they tell me, I've never had one hot flash ever. Those are the people that I aspire to be like. But other women say, I get a hot flash in my year, I have to lay down on the linoleum on the cold floor because it's that bad. So it really does range. It's hard to say how everyone will act. And it's not normal or abnormal, it's just we're all different. This is just quick anatomy. We'll start with the vagina because most of us can see that ourselves. So at the top of the vagina is the cervix, and that's the bottom part of the uterus. So the uterus is the big muscular portion where babies grow, where our bleeding comes from, on that inside lining where it's yellow. That's the inside lining of the uterus. And then the fallopian tubes go out one on each side, and the ovaries are next to those. So that's the white tissue there. And the ovaries, those guys are the ones that are causing the issues around menopause. So when their function starts to decline, that's when we start getting the symptoms of menopause. So blame it on your ovaries. So like I was saying, the ovarian function slows down. When it slows down, the hormone levels that we've been so used to going up and down over the years, whether that's good or bad fluctuations, they really fluctuate a lot at that point. So they're not just going up and down in their normal cycle, they are just crazy all over the place, and that leads to some of the symptoms. So the estrogen and progesterone are two hormones that decrease, and follicle-stimulating hormone is one that increases. Now, are those really something that we recommend being checked? Going to your doctor and saying, hey, am I in menopause? It's really a clinical diagnosis. So when you hit that 12 months of no periods, that's when we can say you've been through menopause. If there's some extenuating circumstances, and say you got to 60 years old and you're not sure if you're having a period or it's postmenopausal bleeding, sometimes we check an FSH. If it's really, really high, that tells us you're in menopause and you're actually having postmenopausal bleeding instead of a normal period. But it's not a usual lab draw that we do. So some of the more common symptoms of the menopausal transition are hot flashes, or sometimes you'll hear them called hot flushes, basically the same thing. vaginal dryness, and then menstrual irregularity. So if you're used to having periods, every 28 or every 30 days, all of a sudden that interval can change. They might start coming more frequently. They should hopefully start spreading out a little bit. You might go 2 to 3 months without a period. You might go 6 months. Once you get to that 12 month, that's when we term it menopause, and you should never bleed again. And if you do, you need to tell me. So what is a hot flush or a hot flash? Hopefully some of you know what I'm talking about. Hopefully most of you don't know what I'm talking about yet. But it's basically a sudden extreme sensation. It can be face, neck, chest. Some people feel it throughout their whole body, but it's usually from about here up. Just very extreme heat sensation. They can be 1 to 5 minutes long. Sometimes people feel almost like they're having an anxiety attack during them. So they feel anxious, their heart might start palpitating. They can get sweaty, have chills, actual redness on their face. So as you can imagine, these may interfere with sleep, and that's why people have sleeping problems too when they start going through menopause, is because they might not even know that they're having hot flashes in the middle of the night, but they are, and it's waking them up and disturbing their sleep cycles. So if you haven't had one yet, this is something to look forward to. Not. So how can we treat the hot flashes or hot flushes? The main kind of medication way that we can treat them is with hormone replacement therapy, HRT sometimes it's called, and that's with estrogen or with estrogen and progesterone together. So if you have had a hysterectomy, then you don't need the progesterone component of it, you would only need estrogen. But the progesterone is used to protect that inside lining of the uterus if you still have one. So this treatment isn't something that every menopausal or perimenopausal woman needs. It's really used for severe hot flashes. And we'll talk about other medications that we can use for some of the other symptoms, but hormone replacement therapy isn't without risk, and so we don't just hand it out like candy. It really is used for severe hot flashes. And you may have heard of other things that people use. Certain doctors prescribe like testosterone, progesterone-only medications. A lot in the media is out there about compounded bioidentical hormones. We really don't support that as far as the data is concerned. So we tend to really try to use the FDA-approved medications. Compounded medicines aren't always consistent in their dosage, and so it's hard to regulate exactly how much estrogen someone's getting, how much progesterone. In the FDA-approved medications, we can monitor that better. So a little bit about estrogen. There's different ways that you can take it. So orally is probably the most common, just a pill. And then transdermally, so that means through your skin, there's gels, sprays, patches. So here's a couple kind of brand names of those. Some side effects of estrogen are things like breast tenderness, bleeding, bloating in the abdomen, and headaches. Not everyone gets those, but it is one of the side effects that can happen. And then this is what I was talking about when some people can get away with just using estrogen and some people need estrogen and a progestin medicine. Progestin it's an add-on medication when you still have a uterus and you're starting hormone replacement therapy. It helps prevent endometrial hyperplasia, which is basically a precancerous condition in women who are taking estrogen. So if you're only on estrogen alone and you still have a uterus, you're really putting yourself at risk for getting hyperplasia or even cancer, a few years later. So the progestin sort of counteracts that and protects the inside lining of the uterus where it's yellow inside. So a couple of the risks of systemic combined hormone replacement therapy, so that's the estrogen and the progesterone, is breast cancer or blood clots. Blood clots can be a DVT, which is a deep vein thrombosis. Like you may have heard of that happening in someone's calf, something like that. Even more life-threatening is when that blood clot can actually travel to the lungs and cause a pulmonary embolism. So these things are rare. They're not going to happen in everyone that takes systemic hormone replacement therapy, but it is something to weigh when you're talking about risks and benefits. So this is what I touched on with the compounded bioidentical hormones. They are plant-derived. They're chemically and structurally similar to the hormones produced in our body. And that's why they're so attractive to people, is because they're a little bit more like the hormones we already have. However, so the non-compounded ones, some of them are commercial FDA approved. So just because you're getting estrogen from me in a prescription doesn't mean that it's not a bioidentical. We have options that are really close to the same exact estrogen that's in your body. So that's usually what we go to first. And then the compounded ones are the ones that aren't FDA approved, and we're sort of worried about how much is in this pack that I'm getting from my compounded pharmacy versus last month. And with fluctuations like that, it can lead to bleeding, and then we're checking out the bleeding. So sometimes it's definitely better just to be on a consistent dose with the FDA-approved medication. Now we'll get into some of the non-hormonal treatment of hot flashes, because there is a lot of talk and risks sometimes depending on what other conditions you may have with taking hormones. So sometimes we need to use something non-hormonal. Paxil is one of the antidepressants. People use it as an antidepressant. Recently, they have come out with a lower dose formulation, which is FDA approved for hot flashes. Now, there are other antidepressants out there that do help with hot flashes. They're not technically approved, but they are used off-label all the time for hot flashes. Clonidine and gabapentin are two other medications that are not technically FDA approved, but they are used off-label for hot flashes. And then, again, complementary botanicals and natural products are not FDA approved. So the data does not actually support that phytoestrogens, herbal supplements, and unfortunately lifestyle modifications are really effective for the treatment of hot flashes. You might be able to decrease them a little bit by certain things that you do, but you're probably not going to be able to get them to go away. So things like the layering your clothes, having the fan with you, all that is good and maybe decreases them a little bit, but it won't completely take them away. So I mentioned phytoestrogens on the last slide. Those are just plant-derived substances with estrogenic biologic activity. So they have that potential for giving you some estrogen through plants. So soybeans, soy products, and red clover are three of the common ones. And again, herbal remedies, these things that you've probably heard of, black cohosh, ginseng, St. John's wort, ginkgo biloba. There's also insufficient data to say that those are actually helpful. And sometimes when people start getting weird symptoms, we're not sure if it's related to all these different herbs that aren't really FDA approved and it's hard for us to research them and know exactly, or is it related to actual menopause? Vitamin E is one thing that has been shown to decrease hot flushes by just one less per day. So you could try that if you're desperate, I guess. And then lifestyle modifications we touched on, layering your clothes so you know you can always get down to a tank top if you needed to, maintaining a cooler temperature, which is easy in Michigan right now. Just go outside. Consuming cool drinks, so avoiding your coffee, your hot tea, things like that. Also, just even if they're cold drinks, avoiding alcohol or caffeine. Front row. That's fine. Those things can actually trigger hot flashes. And I have not gone through menopause myself, but I have talked to many women who, being in sort of like an anxiety-provoking situation or being maybe a little embarrassed, something like that actually triggers hot flashes too. So as best you can, try to limit those situations. If you know you're going to be in a place that you're prone to that and people could embarrass you, things like that, then be prepared, because you might have more hot flashes in a setting like that. Okay, so that is hot flashes. We'll move on to vaginal symptoms. And vaginal symptoms are not always apparent right away with menopause. Sometimes it takes a few years, and it also depends on sort of how sexually active you are. So the fancy term is vaginal atrophy, and that just sounds terrible, and it kind of is. So it's thinning of the vaginal tissue from just not having as much estrogen as you're used to. So, we think of thinning tissue, ooh, good, thin tissue, but no, down in the vagina, that's not something that we want. So 10 to 40% of postmenopausal women will report vaginal symptoms. And honestly, it seems like it's probably more than that clinically. And symptoms can be vaginal or vulvar dryness. Vulvar is like your labia, kind of everything down there. So dryness, discharge, itching, pain with sex. And so all of kind of the dryness in general can lead to other problems too. So it's not just that it's uncomfortable, but it can lead to tearing in the vagina. It can lead to bleeding with sex, also probably from tearing. It increases your risk of getting a urinary tract infection. And then the vagina can just narrow a little bit too, as the tissue is more thin and there's less estrogen there. The vagina is narrowing. So if you are having what we call local symptoms, so say you're one of those women who don't have a lot of hot flashes, you got out of it that way, but you are having the local symptoms with just vaginal dryness, itching, something like that, you can use what's called a local therapy. So you don't necessarily need to take pills and have them work throughout your whole body. You really need a vaginal medication. So vaginal medications come in different formulations as well. There are creams, rings, or tablets that can be placed in the vagina, and how often you do that is based on which medication you talk about with your doctor and decide on. The nice thing about using a local estrogen medication is that you don't need to have that progestin component to it. So it's not associated with that increased risk of cancer inside the uterus, so you don't need a medicine to counteract the estrogen. So if there's any women in here that have maybe had breast cancer, there's hormone-sensitive breast cancer, so if we gave you an estrogen pill, we're actually possibly feeding into any residual cancer, increasing your likelihood for recurrence. So we would definitely try non-hormonal methods first. If there was ever a point where nothing else worked, it would be only in consultation with your cancer doctor, your oncologist, that we would choose to use a hormonal method. There are some non-hormonal medications that we can use as local therapy. So again, if you're just having the vaginal symptoms, Replens is, I don't work for Replens, but I will give it a shout out. So first I'll talk about vaginal lubricants are, just that you would maybe use during sex to decrease friction. It's not meant to be a long-term, a daily medication for long-term use type of thing. It's applied to the vaginal opening before sex. So it's different than the vaginal moisturizer, which is Replens, spelled kind of weird without an E on the end, but it's found over the counter, at Meijer, probably Walgreens, any of the pharmacies. I haven't checked that out for sure, but it is intended to trap moisture and provide long-term relief. So you use it daily to begin with for 1 to 2 weeks, and then after that it can be used every 3 days. So if you are battling vaginal dryness, even before you go to the doctor, say you have an appointment in a month or something, I would give the Replens a shot, because it might be all you need, and then you could possibly avoid hormones or any other medication. All right, so that's enough with the vaginal changes. Period changes are one of the other big things with menopause. So, like I was saying, the intermenstrual interval, so the period of time between your cycles, should increase. So you might feel like you skip a month here and there, you skip 2 months, all of a sudden you're skipping 6 months, 8 months, and then finally you'll skip 12 months. And that's the golden time there. So, like I said, that can usually last 1 to 3, 1 to 4 years before that final menstrual period. So you'll probably start keeping track and thinking, everyone, this has got to be the last one. Sleep disturbance is a big deal with menopause, and sometimes it's because the hot flushes occur at night. And sometimes it's just part of menopause, even if you're not having the hot flushes. So there are some tricks that I can offer. Some of these things you probably know already, but you might not do them, just like me. Some of these seem obvious. Obvious and things we can't do. Like sleep as long as necessary to feel rested. Some of us never feel rested. And then get out of bed. So if you wake up at 7 a.m., don't hang out and read in bed for 3 hours on Saturday morning. Get out of bed, start your day. You can read later. But just getting out of bed kind of triggers your body to know, okay, we're awake, this is our awake time, sleep time is a different time. Trying to maintain a regular sleep schedule. That can be difficult for people who work odd shifts, or you want to sleep in on the weekend. Who doesn't want to do that? But really maintaining a regular sleep schedule can help. Try not to force sleep. If you're really not tired at 9 or 10 p.m., then sometimes the need for sleep is a little bit different as you age. You might not need that full 8 hours of sleep. You may only need 6, and you might feel great. So you don't have to force yourself to just lay in bed, because that will lead to the anxiety of, why aren't I sleeping? Why can't I get to sleep? And then your mind just starts running. And these next ones are kind of hard. Avoid caffeinated beverages after lunch. I'm still drinking my hot tea from the morning, so I'm not good at that either. But that can help if you're having trouble. Avoiding alcohol in the afternoon and evening. And just to clarify, I am not promoting morning drinking. I don't really know where that comes into play, but alcohol does not help with sleep. Sometimes you feel like it does because you can get really sleepy after a glass of wine or something. I get that, but it does not actually help with your sleep cycle and the amount of deep sleep that you get. It does not at all. Avoid nicotine. Obviously avoid nicotine anyway, but for sleep, definitely avoid nicotine, and especially in the evenings. A couple other things, and this is what our technology and our day and age does not help us with, is just decreasing stimuli in the bedroom. So lights, TV, radio, turn them off. Listen to your podcast at a different time of the day. Don't fall asleep to it. Avoid screens before bed. So the people who fall asleep or drop their phone on their face, you know what I'm talking about. Don't lay in bed and look at your phone the whole time. And this next one is especially interesting. Resolve concerns or worries before bed. So, as women, I don't think we can do this ever. This is our time when everything happens. But if there is something that you have on your mind, some women have found it helpful to have a little pad of paper by their bedside table. If there's things, running through your mind, oh, I need to do this tomorrow, I need to do that, just write them down and maybe you can get them out of your mind then. This one is really good. Exercise is obviously good for your health anyway, but it can be helpful with sleep too. So not right before bed, because then you'll be all jazzed up, but about 4 to 5 hours before bed if you can. Exercise for at least 20 to 30 minutes. And then avoid daytime naps. All right, that's all I got on sleep. Depression is something that some people are affected with their whole lives, and some people just feel it starting to creep in their mid to late 40s when this menopausal transition can start, and into their 50s. And is it changes in signals in your brain? Or, that, and is it also maybe related to all the other things that are happening? So are you depressed about, your sex life might be declining, your vaginal dryness is making you upset. There's a lot of things that lead into it where it's a very complicated issue. So it's meant to take seriously. And the sleep hygiene can help with symptoms of depression too. So there's definitely an increased risk of new onset depression during this menopausal transition. And of course, we always recommend non-medication techniques first. Relaxation techniques, the sleep hygiene that we talked about, exercise, sometimes counseling, avoiding unnecessary conflicts and people who anger you. If you just have that friend that you leave your lunch meetings with, you go to lunch, try to have fun, and they're just annoying, it's probably not worth it maybe. So just try to decrease the stress in your life as much as you can, which is sometimes really hard, and it takes standing up for yourself more than you might think that you have the courage for. Another big topic is sexual function/dysfunction. And this I cannot say enough about. So estrogen deficiency, that when those ovaries start shutting down, there is decreased blood flow to the vulva and the vagina. So the labia, the vagina, everywhere has decreased blood flow. And we've already talked about the thinning of the skin, the dryness, the itching. You can help yourself with all of those things, medication or not, by using it or losing it. So it really is, sex is not always super fun at first. Say it's been very painful and dry for a year, so you've had sex one time in the last year. This is going to take some time. It might be painful and uncomfortable at first, but if you can get to a point where you're having slightly more regular sex, it actually will help in the long run, which will make you feel better about yourself. It will make it hurt less, and you might not have as much dryness and all that too. So, and if you don't have a partner, then just do it yourself. Increasing blood flow to the genital region. It's a controversial topic, but honestly, any type of increased blood flow to the genital region can really alleviate you from some of these symptoms. And we've talked about UTIs, tearing in the vagina. None of this stuff is fun to go through. So definitely a use it or lose it phenomenon. And then, if you are one of these women that haven't had sex in a long time, now it's just to the awkward point where, okay, I don't even know how to get back into that. Start with non-sexual contact. So many of us get wrapped up in our jobs and our kids and everything else in our lives that we forget about our partner. So start with doing fun things together. If you used to like to, go skiing, maybe go skiing, something like that, just where you're finding activities that you both enjoy together, and then eventually that might lead to physical enjoyment together too. Cognitive changes, I don't have a whole lot to help you with that, but it is I would just want to say that it's normal, I guess, to have a little bit of memory loss and a hard time concentrating, especially when you have these other things going on. So it's hard to concentrate when you're constantly having hot flashes, you're walking and maybe things feel dry down below and it feels like it's tearing. There's just a lot to think about. Weight gain is another really important thing with menopause. It always is mid-40s. When I'm seeing patients, they come in and say, I feel like I put 10 pounds on and it's all right here in my stomach, in my gut. And it's not that, you may not have changed your diet, you may not have changed your exercise at all. It's just a product of the hormones declining, and that's where the weight goes. So it is something that you do have to drastically change a lifestyle change to something more healthy, to kind of help get rid of that, or at least tame it so you don't gain more. Exercise is good for our bodies. I'm promoting exercise 20 to 30 minutes a day every day, but it shouldn't be used as a primary weight loss mechanism. The reason is because say you work out for 20 minutes a day, you decide you want to lose 10 pounds, so you increase that to 45 minutes a day. Okay, are you really going to do that forever? Probably not. It's a very temporary, right when you go back to your 20 minutes, you'll probably gain all that weight back. So, and I'll talk about this in a minute, but weight loss really is in the kitchen. There's just no other way around it. So I still want you to exercise, I just don't want you to overdo it and go crazy with it as your primary weight loss mechanism. Again, I didn't write this book, I don't know this guy, I have no ties to this book, but I want you all to read it. It's so good. It's called The Obesity Code, Unlocking the Secrets of Weight Loss. I think it's $14 on Amazon, if I remember right. So Dr. Jason Fung writes this book. He's a nephrologist, so a kidney doctor. He deals with a lot of diabetic patients, people with insulin resistance, people with high blood sugar. It's a great book about just a low-carb, high healthy fat diet, really limiting sugars. It debunks a lot of myths about diet and exercise that you may have heard, like we should eat 6 small meals a day to keep our metabolism going. No, you really shouldn't. If your body's always given food, it will just use those calories and never dip into your stores. So you really need a prolonged period of time between meals for your insulin levels to go down and for your body to dip into those stores. So I'm not doing this book justice. I mean, you just have to read it. It's really, really good. He cites a lot of studies. Once you read it, you're like, oh, how come I never thought about this topic in this way before? So it's very good. So he talks a lot about, BMI and what's healthy and what's not healthy. This isn't really a menopause type slide, but I just know that it's a huge concern for almost everyone that I see in my office, so I just wanted to touch on it real quick. BMI is an easy calculation you can do if you just type on the internet BMI. It'll come up with a calculator. Basically, you put in your height and your weight, and then it'll calculate your BMI. Unfortunately, we've all gotten used to seeing just overweight women, obese women, and so when we see a normal weight woman, we think, oh, they're too skinny. They need to eat more. When probably a lot of them are at that normal healthy BMI. So a normal BMI is between 18.5 and 24.9. Overweight's 25 to 29.9, and then obese is 30. And let me tell you, it does not take a lot to get to 30. So we unfortunately are just a very obese culture. And even when we try really hard, we have restaurants all around. It's sort of our social thing to go out to dinner. We're sort of a product of our environment. But I'm hoping the book that we just talked about and things like this will help just a better diet all around. So on that, eating healthy is really good for just your health in general, but it can also aid in helping the symptoms of menopause.